Hello, I'm Dr. Randall Secreest, your host for eOrthopodTV. Today we'll be talking remotely with Dr. Craig McAlllister. Dr. McAllister is an orthopedic surgeon who practices orthopedics in Kirkland, Washington. He's the head of reconstructive orthopedic surgery at Evergreen Hospital in Kirkland. Dr. McAllister did his medical school training at the University of Washington. From there, he did an orthopedic residency at the Albert Einstein College of Medicine. And from there, a fellowship at the Cleveland Clinic in knee reconstructive surgery. Dr. McAllister will be talking with us today about anterior cruciate injuries and the treatment of anterior cruciate injuries of the knee. Dr. McAllister, thanks for joining us today.
Good morning, Randall, and it's good to see you again.
Well, Dr. McAllister, today I thought we would talk a bit about anterior cruciate ligament injuries in the knee. So maybe to start this whole discussion, you could talk a bit about what an anterior cruciate injury really is.
Well, I think it's helpful to start off just talking about what the anterior cruciate ligament does. It's one of the central two ligaments in the knee, and its main job is to really keep that knee stable, especially as the patient is pivoting and rotating across that knee. So when we see patients with anterior cruciate ligament injuries, we tend to see them in two different arenas or situations. One is the acute injury, where an athlete has had a sudden injury, they know they had a sudden injury, maybe they felt a pop and their knee swelled, and we know there's been a new recent injury to the anterior cruciate ligament. The second setting, of course, is where they had an old injury, maybe it got diagnosed and they chose to treat it conservatively, or maybe they didn't even get it diagnosed and they've been living with this chronic anterior cruciate ligament injury and the instability that goes along with that.
Well, let's talk a little bit about the injury and the symptoms of the injury. What do most patients present with as their chief complaint when they've injured their anterior cruciate ligament?
So let's talk about that in the context of the acute injury. Normal knee, probably an athletic patient, any age from 14 up to 40. They've been participating in rapid decelerating stop, twist, turn, pivoting sport. And when they did that, at some point their foot became fixed either on a ski or on the ground with cleats. They twisted their knee. They typically feel a pop. In fact, people around them can sometimes hear that pop, and then that knee swells up within the first 4 to 6 hours. That swelling within the first 4 to 6 hours is a real telltale sign because, as you know, there's a substantial artery in that anterior cruciate ligament. So when that anterior cruciate ligament ruptures, it bleeds into the knee, and that's really one of the only frequent causes of swelling of that significance in that first 4 to 6 hours. Sometimes they'll go to an emergency room, or sometimes they'll just wait through the weekend or through the next opportunity to see a physician or an orthopedic surgeon, and they'll come in with that swollen, sore knee, quite unaware of any instability because the knee's been too sore to really challenge the knee afterwards. And that's typically how they present.
Now, if they choose to ignore this and let the knee swelling go down and try to live with this and don't seek any sort of immediate care, what sort of symptoms are they going to have 2 weeks, 3 weeks, maybe even 2 years after an anterior cruciate ligament tear?
Yeah. Well, that's a great question because, as you know, once that acute swelling goes down, typically 2 or 3 weeks, they'll go from very concerned and very frightened about their new knee injury to very relieved because as we rehab that injured knee and they don't indulge in pivoting sports, that knee will come to feel very normal. In fact, if their knees are reasonably stable anyway, if they have good medial collateral ligaments and lateral collateral ligaments and their muscles are reasonably strong, and they don't indulge in those decelerating activities, they may come to really believe that knee is completely normal. In fact, if they actually rehab that knee, what happens frequently is they'll see a physician. Maybe they'll be aware of that anterior cruciate ligament tear, maybe they won't. They'll go to rehab, they'll get better, maybe curtail their lifestyle a little, and they go on to a very normal feeling knee.
So that brings up the question, and the question is how important is it to treat these injuries? And a second question is really how important is it to consider surgery for these injuries? So to start that discussion off, is there a role for conservative therapy where you don't operate on the knee that has torn an anterior cruciate ligament?
Yes, definitely. Historically, back in the 1980s, where anterior cruciate ligament reconstruction required large sweeping incisions and lots of different tendons being transferred and really questionable results after surgery, the the huge majority of anterior cruciate ligament tears were treated conservatively. And that's still done today. I think that, of course, each patient is different and you have to consider them individually, but it definitely is important to consider conservative treatment. And we have definite parameters on who should be treated conservatively and who should be treated surgically.
Well, let's run through those parameters, because I think that's a very useful way of trying to understand the injury as well as what your choices are as a patient.
Well, again, I want to emphasize that each patient is unique and every patient's situation should be considered in great detail. But I will tell you that as a surgeon looks at a patient and tries to decide between conservative and surgical treatment, there are basically three things that we're looking at. One is age, and the second one is activity level. How many rotating sports, rotating sports are they participating in? And are they willing to modify that activity level to accommodate their new injured knee? And thirdly, while the anterior cruciate ligament is either torn or it isn't, the amount of instability that individual patients will feel is widely different. So if they're an older patient, say over 50, their knee is maybe a little arthritic anyway and getting stiff, they don't necessarily want to participate in high-end decelerating sports, and their knee is inherently stable, we really discourage anterior cruciate ligament reconstruction.
Now, if you look at the patients who you feel like do need surgery, how do they differ?
If you look at the things simply in terms of those three parameters, the younger the patient, the more likely they're going to be reconstructed. Certainly under the age of 25, especially if they want to continue to participate in high-demand sports such as skiing or basketball or tennis or any kind of activity that is going to provoke that sort of rotatory pivoting moment in the knee. The second thing is the amount of instability that they present with, and orthopedic surgeons are very experienced in being able to ferret out how much instability they have based on talking to the patient and on examining the knee and eliciting what we call a pivot shift. If they have an inherently unstable knee and they're young, the long-term results of conservative treatment are actually quite poor.
Now, when we talk about conservative treatment, what exactly does that consist of? Are we talking about rehab? Are we talking about bracing? What sort of guidelines do you use?
Well, unfortunately, particularly in this era of managed care, conservative treatment sometimes is a euphemism for just ignoring it, and they don't really do anything conservatively to treat the knee. Ideally, conservative treatment would include an accurate diagnosis to prove that it's actually just an isolated anterior cruciate ligament tear, because as you know, 50% of these people who tear their ACL also tear a meniscus, and that doesn't really lend itself well to conservative treatment. So first and foremost, an accurate diagnosis, likely from an orthopedic surgeon, and frequently with an MRI. After the diagnosis is made and the knee is examined, a good 4 to 6 weeks after the injury, so that the surgeon can get a sense of how stable or unstable the knee is. So after the diagnosis and after reevaluation after 4 to 6 weeks, ideal conservative treatment would include a brace, an anterior cruciate ligament derotating pivoting brace. They're custom made, reasonably expensive, bulky, and for skiers they need to be fitted to their boots. So the brace is important. And a sophisticated and focused rehab protocol that really includes a physical therapist experience in ACL deficient knees. And then, just as importantly, once all of that is done, a gradual transition back to limited sports, because what we want to know is that athlete able to go back to their activity levels that we've agreed with them that they're going to do, and do so without having instability moments, because it's those giving way episodes that we don't want to have happen and that lead to subsequent new injuries over time.
Now let's talk a little bit about the bracing. You mentioned that the skier wears it attached to his boot, and they're bulky. Sometimes they're a pain to wear. Is this something that the patient needs to wear all the time, or is this something that the patient only wears during sporting activities?
Yeah, they certainly wouldn't do it for routine activities of daily living. So for getting up in the morning, getting in a car, and going to work, no one would wear a brace, except perhaps in the original injury or maybe after surgery. But for long-term conservative treatment, we're really talking about using the brace during athletic activities, particularly athletic activities that involve rotation and pivoting moments.
And in terms of ongoing care, is it just the brace, or are the exercises something that the patient needs to do for the rest of their life?
Well, that ongoing care is really the difficult part because, you know, we've really learned in the last 10 years that there's a big difference between talking about the success in conservative treatment in the first year or two after the injury and then 6 years later. Statistics now show us that people who are ACL deficient have an incidence of upwards 2/3, 65% of these patients will go on to new internal derangement by 6 years. And what we've learned in those studies is that braces tend to wear out, get loose, and end up on a shelf someplace, and that compliance in their exercises and physical therapy and in their restrictions on their activities tend to wane over time. People are normal, and they forget after a while, and then they start to behave normally. They lose their brace, they tend to go back to sport, and that helps to explain why a lot of these ACL deficient knees go on to new internal derangement by 6 years.
And what you're talking about, I think, if I can paraphrase, is that if the patient stops wearing their brace, or the brace ceases to fit, or they stop doing their exercises, they have a new injury and they re-injure or further injure the anterior cruciate and perhaps tear a meniscus or some other structure in the knee. Is that accurate?
Absolutely.
So this is not something that just happens over time. This is a new injury, and they're more prone to that new injury because the knee is unstable.
Yes.
What about the results of wear and tear on an ongoing basis in the anterior cruciate deficient knee? Can you share with us any statistics about how likely a patient is to have, for example, wear and tear arthritis in a knee that's anterior cruciate deficient over a period of time?
Well, we know statistically, study after study after study has shown that patients who have torn the anterior cruciate ligament are at an increased risk for early post-traumatic osteoarthritis, post-traumatic arthritis. While post-traumatic arthritis looks a lot like osteoarthritis, it's a different animal altogether. It's isolated to just that joint, and it tends to progress more rapidly and more likely to go on to requiring further surgical intervention because of the arthritis. So we know that the patient who injures their ACL is at increased risk.
And so do you have that discussion with patients about that risk and put that into the variables about whether to recommend immediate surgery or not?
Not too much. And the reason I don't is because while we know that they're at increased risk for going on to new internal derangement, the studies have not convincingly shown us that fixing their anterior cruciate ligament reduces that osteoarthritic risk, which is an interesting issue. I think one of the things that we're wondering is, well, are studies inadequate in being able to demonstrate this long-term advantage of ACL reconstruction, or is it that those patients, they're active, they're aggressive athletes, maybe their behavior is such that they're going to continue to traumatize that knee, or maybe there's something that happens even at the time of the original ACL reconstruction that sets the stage for that arthritic change. But I wouldn't argue for anterior cruciate ligament reconstruction in order to prevent arthritis. That might help, but we haven't been able to prove that. I think the most solid reason to argue for ACL reconstruction is to eliminate the instability and to prevent new internal derangement later in life, new injury.
Okay, but not necessarily to prevent long-term osteoarthritis, if I hear you correctly.
That's intuitively, it makes sense. We just haven't been able to prove that in the literature, so it's hard to really argue for that.
Well, let's talk a little bit about the surgical treatment of ACL tears. Do you ever use the arthroscope to actually go in and make a diagnosis? Is this part of your routine, or do you feel like that you can get most of the information you need from the MRI scan and the exam?
Yeah, well, certainly prior to the easy access to MRIs, arthroscopy was used as that last definitive measure to prove that somebody had an anterior cruciate ligament tear. But the truth is that an experienced knee surgeon is as accurate in diagnosing an anterior cruciate ligament tear as the MRI is. By the time a knee surgeon speaks with the patient, hears their symptoms, and examines that knee, we rarely even need an MRI to prove that the anterior cruciate ligament tear is a complete tear. So I'd say that by the time we see the patient, talk to the patient, examine the patient, and look at an MRI, we really shouldn't be going to the operating room to confirm an ACL tear. The arthroscope is certainly the gold standard for looking at meniscus tears and other more subtle things that are more difficult to examine for and more difficult to see on the MRI.
So if I hear you correctly, by the time you suggest an arthroscopic evaluation of the knee, you're planning to go in and fix something. You're not just going in to look around.
Yes, that's absolutely true. Certainly the scope helps us fill out a lot of the details, and I think that there are some rare situations, probably 1 in 20 knees, where we're still not completely positive as to whether or not it's a complete tear or a partial tear, and we're confirming that at surgery. But even in those knees, the overwhelming majority are complete tears, and we don't get too many surprises.
Well, let's talk a little bit about surgical decision making. When you sit down to have that discussion with the patient, and you've determined that this patient really is a candidate for surgery and needs to decide, whether to have surgery or not first, and I think we've covered that area pretty well. When you sit down and start to discuss how you're going to fix this anterior cruciate ligament tear, what does that discussion look like?
Well, the first clarification for the patient is that all ACL reconstructions surgically boil down to the same type of surgery. Namely, they're all done arthroscopically. Nobody really does open ACL reconstruction anymore. And all ACL reconstructions will be some sort of graft substitution for the torn anterior cruciate ligament, meaning we don't try to repair the old ACL or keep the old ACL. Basically, drill holes are made in the tibia and in the femur, and a new graft, whether it's hamstring graft or patellar tendon graft or allograft, will be substituted for that old ACL.
And when you start having this discussion with the patient, how do you help them make the choice of what graft type is best for them?
Well, that I think is one of the biggest questions that patients bring to the table. And it's a reasonably important conversation to have, and sometimes a very confusing one for the patients. The truth is that while the basic surgery is the same, I think one of the most artful and surgically demanding parts of ACL reconstruction is harvesting the graft, whether it's a hamstring or patellar tendon. So those two grafts are ones that are taken from the patient. And from a surgeon's point of view, the actual taking of the graft is one of the most surgically demanding parts of the operation. So there are a reasonable number of ACL surgeons out there, I'd say probably 80 to 90%, who will only do one of those. They've learned that type of graft, that's the kind that they like. Certainly on the West Coast, it tends to be predominantly hamstrings, and on the East Coast, it's predominantly patellar tendon. So there's a lot of controversy in orthopedic surgery and a lot of passion and a lot of heartfelt feelings among surgeons about which one of those is the best. And when patients go to the internet or maybe they go talk to different surgeons, they'll come out feeling like, oh no, there's really just one choice between those two.
And do you think that there are advantages to one over the other? And if so, what are those advantages?
I definitely think that each graft choice, where we take it from the patient, not allograft, but between the two options of autograft, hamstring and patellar tendon, I think there are definite advantages and disadvantages. And if the surgeon is willing to master both and offer both to the patient, that's a new conversation for the patient, and we can actually sit down and discuss the virtues of each one for that patient. And so let me quickly go through them, and we can explore that in further detail if you want to. The patellar tendon is a graft where we take the central 1/3 of the tendon from that patellar tendon along with two bone plugs. It is historically the original graft that was done when arthroscopic techniques evolved. It's a very strong graft with a lot of rigidity, and it has two bone plugs on the end, so we're actually fixing bone to bone. So it tends to be one of the more rigid, more stable, and more rapidly healing graft choices that we have. The hamstring tendon is taken from the back of the thigh. We actually take two hamstrings, detach them from their muscles, double them up as what we call a quadrupled tendon, and then we use it to replace the ACL. Its advantages are that the overall wound to achieve the graft is smaller. It doesn't have those bone plugs, so it's a little bit more elastic, and patients' rehab tends to be a little bit easier. And they don't have as many problems with pain in the front of the knee as they rehab in that first year. So from the point of view of cosmetics, ease of rehab, and overall range of motion, I think that the hamstring tendon tends to be one of the more favored grafts.
Now, you mentioned the third, the allograft, which for patients, that's a graft that we get from some type of a tissue bank or something like that. That's tissue that comes from someone else. What are the advantages and disadvantages of the allograft, and when would you suggest that?
Yeah, so allograft has really enjoyed a rather incredible popularity from about 2000 to 2009. I would say that the single most attractive feature of the allograft is that the surgeon doesn't need to go through the trouble of harvesting a graft from the patient, and the patient doesn't have to deal with any of the kinds of what we call morbidity from the graft harvest, meaning they don't have any hamstring soreness, they don't have the pain in the front of the knee. And because we're just slipping a graft that's been taken from the freezer into position, the wound can be very small. So I think certainly a big part of its popularity has been the ease of the surgery and the cosmetics and the ease of rehab after surgery.
And you know, years ago there was some effort to build an artificial graft, and I know that several of those things have been on the market for a while. Do you think that that's still a viable option, and do you think we're going to see more of that in the future?
Well, I think you know, they have been tried. Carbon fibers, all kinds of different synthetics, but they've all really suffered the same problem, and really part of the problem with allografts is also related to this, and that is, in order for this graft substitution to really work, it has to be incorporated by the patient's biology and become a new living ligament. Otherwise, over time they wear, and in the synthetics, invariably what they've done is gone on to have wear and then particulate matter within the knee, and really horrible results. As late as the 1980s, we were still using Gore-Tex grafts and incorporating them inside of patients' autograft, hamstring typically. And those did better because the idea was this synthetic was going to support the graft while the graft was healing. But even they eventually fragmented and started to shed debris in the knee and were basically abandoned.
Do you think we're going to see anything on the horizon that goes back to the notion of trying to create something artificial that is somehow incorporated into the patient's biology, to use your term?
Well, I think the answer to that globally is always true. There's no question that, you know, it'd be nice to just have a mechanical or synthetic alternative off the shelf and just put these in patients' knees for a wide variety of reasons, much like knee replacement surgery. But I'd say, if anything, there's an increasing amount of interest in biologics and using cell lines to grow biological substitutes where we don't have to take it from patients. And right now, that seems to be the more promising avenue for the next 20 years.
And what you're saying is that somehow we would take stem cells from that patient, the patient that's going to receive the graft, and use those stem cells to actually grow a new ligament substitute that would share the biology of the patient.
Yeah, wouldn't that be exciting if we could actually take the patient's stem cells or other uncommitted cells from the patient, perhaps one of their ligaments, use a scaffolding in the lab that is actually formed like a complex ACL, and then grow a ligament that belongs to that patient. And we've done that sort of thing successfully in cartilage, in the world of cartilage replacement, but it turns out to be wildly expensive and no real data to support it. So I don't really see that as being relevant in the next 10 years, but it's an exciting avenue for the long term.
Well, let's talk a little bit about the surgical procedure itself. Is this an outpatient surgical procedure, or if I'm a patient, am I going to expect to stay in the hospital for a night or two?
Well, I'm going to answer that for our area, where outpatient surgery is clearly the standard of care. In fact, we're doing outpatient total hips and total knees now. So there's really very little reason to do these kinds of surgeries in the hospital. And there are great advantages to doing them on an outpatient basis, including more emphasis on pain control after surgery, more rapid mobilization for the patient, and eliminating some of the complications related to laying in bed, and just not being exposed to an environment where patients are being treated for very serious medical problems and therefore resistant organisms and that sort of thing. However, outside of our zip code, in some smaller cities, there may not be those opportunities, or maybe they're doing outpatient surgery in an inpatient setting, which probably is not as advantageous. So there are other circumstances such as insurance issues where patients simply have to get their ACL reconstructions done in traditional hospital settings, and those work fine as well.
And what happens after surgery? If you're in an outpatient facility, you go home, are you being seen the next day by a physical therapist? Are you back in to have the wound checked? What sort of happens in that immediate post-op period?
Well, we're very serious about our outpatient protocol here, and we believe that the surgery protocol actually begins a week or two before surgery. During that time, we may actually have a patient visit with a physical therapist so that they can learn some exercises that they're expected to do before and after surgery. We also make arrangements for some of the elements of their early rehab to be delivered to their home prior to surgery, including a continuous passive motion machine, the brace, which we expect them to be able to have fitted and comfortable for them even before surgery, and cryotherapy, ice therapy, an ice machine, because we really do believe that this notion of multimodal pain management is a big part of what allows a patient to mobilize early without a heavy use of narcotics. So we think that our rehab protocol begins virtually in the recovery room when we put that patient's leg in a cryotherapy machine and in a continuous passive motion machine. They typically go home from there, usually an hour after the surgery, so they might actually be in our surgery center for 2 or 3 hours. And they're usually typically pretty awake. My son actually had an ACL reconstruction, so I've had the opportunity to see it from the patient's point of view. And so he was up and mobilizing pretty quickly, getting over the effects of the surgery. But a lot of emphasis on ice and elevation in that first 3 days, and really leaving the dressing intact. And then we like to see our patients at 4 or 5 days after surgery so that we can do a wound check.
And then when do you start formal physical therapy again afterwards, where you're actually meeting with the therapist and beginning some more aggressive exercises?
I'm a big believer in making sure that wounds are mature and sealed before I put my patient in an environment where other patients are being treated. It's the other patients that are being treated that sometimes have been on antibiotics and have resistant organisms, and so I don't care if it's a hospital or a physical therapy center I'm not familiar with or whatever. I don't really want to send my patients out into those kind of combined patient treatment environments until the wounds are mature. So that's typically at 5 to 10 days. So when they come in for that 5-day appointment, that's when we're giving them their physical therapy referral and asking them to go and make their first physical therapy appointments.
And in terms of that latter stages of rehabilitation, how long is that going to last? Sort of, can you sketch out what a typical pathway for a patient is when they begin physical therapy? You know, how long is it before they can fully weight bear? How long is it before they can do certain milestones like drive a car and those sorts of things?
Well, instead of talking about the typical therapy protocol, I'd like to talk about the ideal physical therapy protocol. Because unfortunately, as you know, these days the physical therapy protocol can be greatly limited by the patient's insurance situation. Insurances can arbitrarily limit the amount of physical therapy that patients have, so we have to be careful about that. But in an ideal world, I like to think of physical therapy after knee surgery as being 3 phases related to their time after surgery and how many of their milestones have been met. The first phase is right away, getting them in there, getting their range of motion reestablished, getting them firing their quads, advancing their weight bearing rapidly. We don't really have an interest in restricting their weight bearing unless the patient's going to abuse that and be overly active. We'd like to have them weight bearing right away. Better bone quality, better muscle return, better overall function, more rapid reduction of their swelling as they get those muscles firing. So the first phase of physical therapy is largely in that first 6 weeks, and it's focused on getting the patient up, mobilized, back to their activities, driving, back to work. And we don't really have any interest in restricting those activities, of those basic activities of daily living, and encourage the patient to go back to them as soon as they feel qualified to do so.
And how long is the physical therapy last? I mean, again, ideally, how long are they going to be working with a physical therapist before they can pretty much say, I'm done and now it's up to me and I take it over from here?
Yeah. So the second phase of physical therapy would likely be in that 6 weeks to 6 month time. And that's when we are going to be meeting with the patient intermittently and reminding them that there's a biology that has to occur in this healing and incorporation of their new graft. So realistically, their muscle tone and their range of motion and their feeling that they could go back to sport come back much faster than what we're willing to release them in terms of the biology. So there's a lot of emphasis in that first 6 months on range of motion, muscle tone, gait, and then as we get to month 4, more and more emphasis on rotatory activities and pushing them towards the kinds of activities that would mimic their return to sport. And then in that 5th month, a lot of emphasis on actually now engaging them in sporting activities so that they can go back to sport, typically released at 6 months.
And you mentioned there's a third phase as well. Tell us about the third phase.
Well, I've always felt this way, but I became acutely aware of it as I watched my son return to competitive basketball. When we do this surgery and we give them a new graft, and then we put them in physical therapy and rehab, and we give them a brace, and we get them ready for sport, they can go back to sport at 6 months, but every ACL patient who has attempted a return to sport at 6 months will tell you they didn't feel right and they didn't feel confident until about 12 months or 6 months of return to sport. And that's because besides the confidence issues and just the memories of that ACL tear and the surgery, new skills have to be obtained. And you know and I know that the native ACL is also it's a proprioceptive organ. It had nerves in it that help the patient understand how to use that knee and how to be confident in it. So the third phase for me, which can involve a physical therapist on a more intermittent basis, is helping them come back and be competitive in their sport, which takes probably a good 12 months after the surgery.
And you feel like that they still need to be engaged with a physical therapist to help them through that 6 to 12 month period, that they don't do this is not something they do on their own, but with the assistance of a good physical therapist that understands these type of injuries?
Well, realistically, very few of my patients really take advantage of that third phase. I think it's more focused towards the real serious athlete, that not the weekend warrior so much. It might be that high school athlete who's trying to achieve a college a scholarship, or a collegiate athlete who needs to get back competitively, or that highly motivated athlete who's as interested in getting back to sport as they are getting back to their routine activities of daily living. So for that motivated, aggressive, if not elite athlete, no question, if they were a professional athlete or if they were at a Division I college, they would be doing that third phase, absolutely.
Well, let's talk a little bit about the potential complications of surgical repair or surgical reconstruction of the anterior cruciate deficient knee. What are the sorts of things that you worry about as a surgeon when you're doing this surgery?
Well, certainly the one that we worry about the most is recurrence. And that's why, we didn't talk too much about the disadvantages of allograft. I strongly discourage allograft reconstruction as the first choice in a first-time ACL tear, largely because of this recurrence issue. Allograft reconstruction is very popular from the early point of view, where there's no graft harvest and no donor site issues and small wounds and ease of rehab. But in the aggressive athlete, in the patient under the age of 21, the recurrence rate is 25% when we use allograft. And I think that probably makes sense when we think about it. Remember, I said the graft has to be incorporated by the patient. Well, obviously it's going to be a lot more biologically conducive to incorporate the patient's own tissue than it is to incorporate a dead frozen allograft from the freezer that belonged to somebody else. There are also significant complications associated with simply the use of allograft. Because it's foreign tissue and because it takes so long to heal, about 15% of those patients will have chronic effusions, chronically a year or two later, very swollen knees that really interfere with rehab. And they may actually get what we call large bone cysts. They get holes around the tunnels where that allograft is attempting to heal. So if they fail, which happens in 24 to 25% of young patients, and then we have to go back and reconstruct them, we tend to find these big holes left in the bone where the allograft was placed. So definitely recurrence, especially in the setting of allograft, is a big concern that we have.
And what about the patients that you have not used allograft on? Are you still worried about recurrence as your primary concern, or are there other problems?
Well, I think that in the autograft ACL reconstruction that's well done, without any technical errors, in a compliant patient, the recurrence is on the order of 0.5 to 1%, even in aggressive athletes, probably higher in the more aggressive athletes. Interestingly, in my patient population, which encompasses probably on the order of 700 to 1,000 ACL reconstructions, our recurrences have been more commonly in the patient's other knee than in their reconstructed knee, which speaks to the fact that ACL patients as a group tend to be a reasonably aggressive group of athletes who expose themselves to risk. So there's definitely concern even in the autograft reconstruction, but I think that has to do with concern about the patient and their activity level more than it does the surgery.
Well, and today, with these new techniques that you're talking about, what do you consider the statistics to support ACL reconstruction? I mean, have we solved this problem? Is this a problem that in the right hands that you can count on a very good result, or are we still trying to figure out better ways of doing this?
Well, there's no question in my mind that ACL reconstruction is better than the alternative of leaving a patient who's active with an unstable knee. No question. ACL reconstruction today as an arthroscopic outpatient surgery is far superior to where we were in the 90s, and it works to eliminate instability. I wish we had what you were talking about, a real viable biological, genetically identical graft substitute where we didn't need to harvest the graft from the patient. I also wish that we could prove, or we could figure out how to do these ACL reconstructions and not have those patients end up with arthritic knees. Those would probably be the two biggest wishes that I would have going forward.
Well, and as we close this discussion about anterior cruciate ligament injuries, is there anything you think patients ought to know that we haven't discussed to this point?
Well, I would just emphasize that as long as there aren't other injuries in the knee or other confounding factors, patients should understand that after they've had an injury to their ACL, there's no rush to get the surgery right away. They have time to allow that knee to improve and get better and have the range of motion and muscle tone come back before surgery. And also, they have the time and the leisure to do their investigations and really decide what's best for them, and to understand that what's best for one patient may not be the best for another patient, and that it pays to do their research and get a couple of opinions and really make a solid decision about what's best for each patient.
I think that's excellent advice, and on that note, we'll close this discussion. And I look forward to further discussions about different types of knee injuries and perhaps some of the more complex issues that face the patient who's had an anterior cruciate ligament injury with some other injuries thrown in for good measure. So thanks so much for talking with us today, and look forward to further discussions.
Well, thanks for having me. It's good to see you again, Randall.